بسم الله السلام عليكم. الحقيقة أنا سعيد جدا بالتواجد مع زملائي وأساتذتي، ما نعرفش نجمع بعض كده كتير يعني فده تنظيم يعني هايل جدا إن إحنا نعرف نشوف بعض. يعني نتكلم النهارده كده يعني على our own experience ورأينا في العيانين اللي هم beyond the early stage lung cancer. وhistorically في كلمة T4 لما بتيجي قصاد thoracic surgeons بتيجي قصاد oncologists, this means patients are inoperable. فهل ده بينطبق على كل الحالات ولا لا؟ Just to recap, lung cancer is the leading cause of death among cancers in developing countries. The most common is non-small cell lung cancer, representing about 90% of all lung cancers. And we are using the 8th edition of the TNM classification since about nearly 6 years now. The database for the 8th edition was quite a large number of patients, 77,000 patients, the majority of them from Europe and Asia. These are the changes from the 7th edition. We all know, particularly, we're talking about the T classification. This has the most number of changes over the edition, with some changes to the M classification, having an M1A, B, and C rather than an M1A and B, respecting size and respecting the number of metastases extrathoracic. And you can see the stage 3A was historically known to be a stage of N2 disease. Actually, it's not. Only 2 out of 5 possibilities of stage 3A are N2 disease, while the other options are patients with locally advanced lung cancer, T3 and T4 patients. So these will lie in the stage 3A criteria, and this is what we want to discuss. So what's a T4 disease? These are the possibilities of a T4 disease. Putting a T4 disease as a tumor which is larger than 7 centimeters has allowed us as thoracic surgeons to operate on more number of T4 patients. So this is one of the most common possibilities that we operate on T4 patients. Large tumors. This is the most common indication of surgery. You've got an ipsilateral cancer in one lobe and another metastasis in the same lung and another lobe, that's a T4. Invasion of the mediastinum, esophagus, trachea, SVC, aorta, and left atrium, invading the diaphragm. This has changed from the old classification from a T3 to a T4, invading the spine and tumors invading the crown. So the T component is important, and we need to calculate it correctly. So do you use a mediastinal window or a lung window? So you can see in a patient like this, you calculate the tumor on a mediastinal window, and it's less than 5 centimeters, so it's a T2B. You put it on the lung window, and it's a 5.2 centimeters, and it's a T3, so it's a different staging. So we need to unify that. We use the lung window as the measurement of tumor size to allow one standard. So as previously discussed by my professors, you always need an MDT. And I think there in Egypt and in many places, you can have dangerous pathways for patients with lung cancer. So you can have a patient with operable lung cancer, sees an oncologist, doesn't seek a surgical opinion. Maybe surgery was a possibility, but the surgeon never seen the patient. And the other way around, you can have an oncology referral to a surgeon, get it from a general surgeon, from a chest physician, and the surgeon sees the patient. He achieves good results. He gets an R0. That's what the surgeon wants, and he tells the patient, "Congratulations, you're cured." Whereas the possibilities of adjuvant therapies now, there's booms of adjuvant therapy, and he doesn't get a chance to explore these options, and he gets discharged, doesn't see an oncologist. This is a suboptimal pathway. So to get a proper MDT, you need, well, ideally, you need most or all of these specialties in your clinic. The core of the MDT is a clinical oncologist, a thoracic surgeon, a pulmonologist, a histopathologist, a radiologist, and a practitioner nurse. You can get better service if you have a physiotherapist, a palliative care team, social worker, psychologist, and you can do some research on your patients. So I had the chance to put some of the MDT guidelines for management of early stage lung cancer in the Middle East and Africa. One of our recommendations was that we consider T4N0 and T4N1 patients for stage 3A operable lung cancer. They should be given a chance for upfront surgery after a proper MDT discussion. So this is what's common. A large white upper lobe mass, 8 centimeters. This is a T4 lesion. You think it's operable, think it's resectable, and got lymph nodes. Can you go for upfront surgery? Yes, you can. Another large tumor in the right upper lobe. It's a 9 centimeter right upper lobe tumor with no distant mets. And just thoracic surgery tip, don't leave the vessels to the end. So seen catastrophic events when sometimes it's easier to cut the right upper lobe bronchus before the vessels, but if you leave a 9 centimeter tumor swinging in the right upper lobe, just connected to a pulmonary vein or pulmonary artery, it may just rip it off. So this is another T4 right lower lobe tumor. And in these patients, I advise mediastinal lymphadenectomy rather than mediastinal lymph node sampling because you have higher chances of lymph node mets on an N1, N2 basis, and patients need to be properly staged to receive proper adjuvant therapy. So a left upper lobe tumor with a met in the apical segment of the left lower lobe. This is another T4 lesion. Go for a lobectomy on the lobe, which has the primary tumor in it, and you go for a sublobar resection, segmentectomy, or wedge resection for the metastasis with curative intent. And this is a nice paper. It says large number of patients. They've looked at 4,800 patients, and they were looking at the TNM classification regarding patients with T3 and T4 advanced lung cancer with no nodal metastasis in comparison to patients on the stage 3A who've got N2 disease. There's a big difference in survival. So 3A patients, they're not all the same. N2 disease, that's worse prognosis. T3, T4 with no nodal metastasis, you can go for aggressive radical treatment because you get better results. So it's a patient with it's like a right upper lobe tumor. There's obvious invasion of the spine. And you need to call your neurosurgeon friend to tell him, can we get this all out? Can we have an R0 here? And again, it depends on what your friend thinks, because if you can't get an R0 here, there's no point for upfront surgery. This is a patient with a right upper lobe tumor. There's invasion of the superior vena cava. These patients need to be considered on a case-to-case basis with good venography to tell you if you can do a good SVC replacement. If there's no nodal mets again, and this is the only site of tumor, you can consider caval replacement or caval reconstruction here. Advise a midline incision, a sternotomy, or hemiclampsia to the right side. Well, this is a good clinical sign of inoperability. So patients think we've got hoarseness of voice. This is sometimes the first clinical sign. You see the patient in the clinic and his voice has changed, and you do a CT and he's got a left upper lobe tumor or an N2 disease. He's inoperable. You shouldn't really bother to go in, because you will have invasion of a significant part of the aortopulmonary region or the arch of the aorta, and he's got a left vocal cord paralysis. So patients with hoarse voice, they're inoperable. Invasion of the carina. This is something that we have a great interest in, which is central airway tumors and airway reconstruction. So patients who've got T4 disease because of carinal invasion, they can be operated upon, again, with the two conditions, and I'll show you the evidence for that. Two conditions. You can get an R0, there is no nodal involvement. You can get an R0, there's no nodal involvement. You can go for upfront surgery. You'll reconstruct the carina based on a tension-free anastomosis. If you've got a small tumor like that, you can resect the carina, anastomose the right main bronchus or the left main bronchus, and put both on the lower end of the trachea. If the tumor is extending down to the right upper lobe or the right main bronchus, you'll do a resection and you'll anastomose the right bronchus intermedius to the distal trachea if you have length. If you don't have length, you anastomose the bronchus intermedius to the left main bronchus. Again, this is a carinal resection with right upper lobectomy. You can do a sleeve pneumonectomy if there's invasion, deep invasion into the left main bronchus or deep invasion into the right main bronchus. You anastomose the spared bronchus to the lower trachea. You can use bypass or ECMO, and we've observed a significant difference. Obviously, with ECMO, there's a lot of logistic issues and financial issues, but there is a big difference. If you need bypass and if you need ECMO, the rate of post-operative bleeding is very different. If you use bypass, you get significant bleedings after carinal resection, which is much less with using veno-venous ECMO. So just a quick presentation of one of our patients, a 72-year-old male with a good performance status. He's got some interstitial lung disease, and he's got a mass in his left lower lobe. It's an adenocarcinoma. He's got sufficient lung functions. His diffusion is 70%, and his post-operative DLCO will be satisfactory. He needs 4 segments to be resected. This is his CT. There is a left lower lobe mass, and it's difficult to detect it here, but there is invasion of the diaphragm. So this is a T4 disease. He's got a query N1 uptake with an SUV of 3. Dr. was talking about these patients who you sometimes do a lymphadenectomy and you don't get anything in the nodes, and he is right. So intraoperative, the diaphragm is invaded by the tumor, and hence we open it. We check that there's no abdominal extension and put a Purolene mesh, and we do a mediastinal hyolymphadenectomy, and we take the left lower lobe out, and you can see that's a portion of the diaphragm sticking to the diaphragmatic surface of the left lower lobe. So it goes home quite quick, and we've got an adenocarcinoma with free margins, T4 disease, all lymph nodes are negative. These patients, they need adjuvant treatment. Can't operate on a T4 patient and just send them home. Even if you get lymph nodes which are negative, there is evidence that patients who've got large tumors, more than 5 centimeters on the calcium and leukemia group B2 trial, they benefit in survival from adjuvant treatment. So he sees 4 cycles of chemotherapy and a PET 14 months after the procedure shows he's free from any residual disease, and he's on a follow-up pathway, and this is how his tumor looks like. So again, you can see that the results of surgical treatment of advanced lung cancer, you can operate on patients with diaphragmatic invasion, although there are grades of diaphragmatic invasion. So you can just have diaphragmatic pleural invasion and muscle invasion. Up to these 2 stages, that's fine. You can resect the diaphragm. If it goes into the abdomen, there's peritoneal invasion. These patients will have a poor prognosis and probably should be closed. And that's the reason why diaphragmatic invasion has been upgraded in the T8 TNM classification from a T3 to a T4. This is the core of my presentation. You can operate on T4 patients. This is the French group, Dartevel and his colleagues. Quite a long history of study on patients who've got advanced lung cancer and T4 disease. So what to look for? Complete resection, no nodes. If you've got complete resection and no nodes, you get good results with these patients. They can receive adjuvant treatment, and you've done your patient a good job. If they turn out to have N2 disease, this will worsen the prognosis. Again, it's the same concept again, operating on T4 patients. If you can take it all out, and if you have no nodes, however aggressive you are, you can get results. So we can operate on all these patients. Probably the white column here, invasion of the mediastinum, esophagus, aorta, and left atrium probably are not operable. But all the other T4s, large tumors, tumors from an ipsilateral lobe, tumors invading the diaphragm, the spine, and the vertebral column, they can all come out. Obviously, you may need some specialized center. So it's feasible with promising results if combined in a multimodality approach and specialized center. Again, repeating the same conclusion, the completeness of resection and absence of N2 disease are cornerstones to better survival in T4 patients. And obviously, these patients needs to be discussed in an MDT. Thank you.